Good afternoon. My name is Evan Turner, and I'm here today to talk to you about how we can, number one, understand how the bell scope is used, how you should feel more comfortable using it, and how we can get patients to understand the value of the service that you're offering. So, with that, let's move forward real quickly. We only have an hour to go through this training, and from that, I would ask you as I'm going through this, please ask me any questions that you might have. First and foremost, I think it's really important to understand that this is about really, at most importantly, saving lives. But the critical aspect of that life-saving capability is finding things as early as possible. So just like mammograms, pap smears, PSAs, it's about screening. It's not about diagnosis. And by detecting an abnormality at the earliest possible stage, we can hopefully prevent that cancer from ever forming. But I also want to reinforce that Velscope is about oral health. This is an oral health appliance, if you will. And we'll talk about how we're going to utilize this in our overall examination and assessment to assist us in a variety of different applications. It's not just about screening for oral cancer. But as I say that, obviously oral cancer is important. And I just want to make sure you're very well aware of why this is so important, why you need to be screening every patient, preferably with the Velscope. And it's because the numbers continue to increase. Almost 50% increase in 10 years. It's just pretty phenomenal. And I know you're more aware of it. The dental community, in a sense, is more aware of it. What is not, in terms of population, is your patients. Your patients don't really know what's going on. And it's an opportunity for you to share why it's so important that they get, number one, not only a thorough oral health examination by you, but then also obviously why Velscope should be part of that oral health examination process. So I'll ask you a quick question. What do you think are some of the top 10 cancers out there? Most people say colon, breast, skin, cervical, prostate. And those same answers that you would give are basically the same answers that your patients would give. What you're going to find pretty much never is that you would get a response that oral cancer is a top 10 cancer. It is now the 6th leading cause of cancer among men, 9 among women. If we look at something that women have generally on an annual basis, the pap smear, obviously that's used to screen for cervical cancer. You basically have a 4 times greater likelihood of getting oral cancer than cervical cancer. But what is it that we do? What is it that women do on an annual basis? They get a pap smear. They get not just a examination visually, there's actually a process that they're screening for. And that's what we have to do with your patient. We have to help them understand that this is just as important as other forms of screening, because it helps us see more. It helps us capture things hopefully earlier and avoid this number, and hopefully get this number to go down. So one of the biggest challenges, though, for you as clinicians is that we all know HPV now is a leading cause of oral cancer. It's important, though, to understand that most people think it's smoking and drinking or elderly or cancer, and you may have heard the response, or you may hear it, that, oh, I don't smoke, I don't need it. No, Mr. Smith, you actually do need it. And the reason being is oral cancer is no longer a smoking disease. Oral cancer now is a viral disease. It is caused by a virus that causes cervical cancer, and now actually, unfortunately, other forms of cancer. And the challenge is we can't detect that, unfortunately, with our naked eyes, especially now that it tends to be at the back of the throat. So it's critical that we're doing a thorough oral health examination, first under white light, but then with the Velscope, when we do it, we have to get exposure. We have to get that patient to say as wide as possible, as well as pulling that tongue to the level of discomfort, so that we can see those posterior lateral borders of the tongue where we're finding more and more HPV-related lesions are forming. So I think it's important, just because to reinforce this issue of HPV, that most some of the initial studies of what it was just being caused by the transmission of virus via oral sex, but now they're finding the virus can be transmitted just through open mouth kissing. So what does that mean? That means everybody is at risk. Doesn't matter, partners, doesn't matter your age. it means that unless you are living in a bubble, you potentially could be infected. Doesn't matter if you've had Gardasil, because there's studies that show that Gardasil may not be effective based on how it was administered. So from that, we have to assume everyone's a high risk category, and therefore everyone who you deem as being an adult will get this examination. So obviously, if we look at 50+% of all cancers that are now HPV related, that says screen everybody. But then when we add in age, when we add in smokers, when we add in diet, when we add in, more and more inflammatory or I guess immune diseases, all of these potentially show increased levels. So when we look at all these categories, basically the majority of patients are at high risk, and this is why we have to screen everyone. So you can establish whatever your protocol is, but the normal protocol or standard is at least once a year, we're going to do a thorough oral health examination, including the bell scope. Obviously, doctor, if you have a patient who thinks of a higher profile or higher risk profile, you may want to screen them more regularly. And obviously, that's a discussion you'd want to have with the patient or hygienist. One of the things I think is critical to understand, and I'll probably be reiterating this, but Velscope is part of your overall examination process. It is critical that you do what you do every day, right? You update your patient's history. You may ask questions about their medication, because obviously, perfect example, high blood pressure medication can lead to dry mouth. Dry mouth actually can lead to issues associated with what they're finding, potential increased risk of oral abnormalities. So health history, Q&A, follow-up. We're going to do an extra and intraoral white light examination. So we're going to palpate extraorally. You're going to feel the neck. You're going to feel the nodes. You're going to make sure that obviously there's no lumps or bumps. Intraorally, under your white light, you're going to do your normal examination. And then obviously, once we've done that, we may identify something of concern under white light, so that we're going to take a mental note, so that when we obviously look under Velscope, we're going to maybe have a little more focus there. But when we see something under white light, go back to the patient. Ms. Smith, I noticed something in your roof of your mouth. Do you remember jabbing yourself maybe with a utensil or something? And we're going to do the same thing under Velscope. So we've gone through this process. We bring in Velscope into that process. Maybe we identify something now that's not readily apparent under Velscope. We're going to talk about the processes to further assess if that abnormality is of concern or not. But at the end of the day, as you go through this whole complete assessment, you should have a pretty good understanding, is this something that I can observe, or something that I probably am going to want to refer potentially maybe in a couple of weeks to a specialist for review. So as we go through the process, I think you're going to understand how we can easily develop a treatment plan that's going to help you assess sort of how to manage that patient. So you see, at least in 30% of your patients, some form of abnormality. And I feel pretty confident in not referring 30% of your patients every day to a specialist. That's because you assess, you ask the patient questions, you make a differential diagnosis, maybe have the patient come back after a couple of weeks, you maybe make adjustments, what have you, but you make a determination that you're going to either monitor or it's nothing of concern. Obviously, if you have something of concern, then, which in rare cases, then you'll potentially refer accordingly. But the reality is you make an assessment and then determine. And that's all we're doing with Velscope. We're going to assess your abnormality and determine, is it something of concern or not? That's all we're doing. We're not diagnosing. We're not determining if the patient has cancer. We're just determining sort of on a scale, is this something that requires definite follow-up, or something that, we can consider when we have the patient come back, in 6 months. So just to reinforce, both for yourselves what you're doing, but then also potentially for your patients. This is an FDA-approved technology predicated on substantial clinical data that demonstrates that this product is effective in detecting abnormalities, potentially precancerous and cancerous abnormalities. So if you have a patient, they say no, we always want to ask why. And it could be because I've never heard about this before, why does my physician do this? you're going to now reinforce this is something that's been used in the medical application for a number of years, but for specifically lung cancer screening. But more importantly, we are the most skilled at doing thorough health examinations, and therefore this tool is actually perfect for us to do this examination. So right now, 70% of all oral cancers are found at the late stage, generally 70 at stage 2 and greater, unfortunately. And that's why the mortality rate hasn't changed in the last 30 years. It's still almost close to 50% mortality. That's pretty scary. At the end of the day, the only way we can avoid cancer is to find it in a precancerous state. And that's where Velscope comes into play. So our goal isn't to find it at the cancer stage. Our goal is to find it below the surface, which is very difficult to see if you can see it at all. And again, Velscope allows us to see those changes below the surface, and we'll talk about how we do that. So back to that question to the patient who may decline. Why, Mrs. Smith? What are your concerns? Our initial thoughts are it's always about money if we're deciding to charge, but sometimes it's about concern that it's going to hurt, that it's harmful. So it's important to understand this is a safe blue light that literally has an intensity that goes down to the basement membrane where those abnormalities begin. And when those abnormalities begin, what it wants to do is grow, right? Specifically, if it's dysplastic, if it's precancerous. What we're doing with the Velscope is, with that blue light, we're exciting a variety of things in the tissue, but sort of the one area that we're most focused on is the collagen in the basement membrane. And when that collagen, which is quite fibrous, is normal and healthy, it absorbs that blue light and gives off a response, and that response is called fluorescence. Which we can't see with the naked eye, but the filters in the handpiece capture that response. So when the collagen is normal and healthy, it appears green. But what happens when we have dysplasia or cancer, what it does is starts to break down that collagen. And once that collagen starts to break down, it can no longer respond. So instead of seeing green, we see dark or black. But again, really important to stress, this is safe. There's no radiation. There's no damage to cells. It literally is a safe blue light. And we're just actually able to see a reaction of the tissue in a safe, natural way. So all the things that are involved, obviously, with the response of the tissue, and I mentioned collagen, but there's a variety of other things. It's pretty remarkable how a safe wavelength can provide information for us to assess if our tissue is normal and healthy. So besides precancer and cancer that's going to show up as dark or black, there's two other things that will absorb this wavelength. Melanin, which is in pigmentation, which we'll go through, and then hemoglobin, which is in blood, which actually is great for us because it's going to help us to differentiate between things that are normal and abnormal. So 98% of the time, all we're going to see is healthy green tissue, right? And I mentioned hemoglobin, so you can notice there's some vascularity, which is what you're going to see very commonly with Velscope, and that's, again, the hemoglobin that's showing up. It's important to understand, though, that we're not throwing away the skills that you currently have when it comes to your examination, right? So when you do a white light examination, you see something abnormal. What do? We assess. Is it unilateral or bilateral? Is it a regular shape? Obviously, if we can palpate it, how does it feel? Is it firm? Is it soft? Does it persist for 2 weeks? So we're still using that same criteria for Velscope, symmetry being a key criteria because, as I mentioned, especially now when we have certain seasons, where it be maybe in spring and fall with allergies or winter with colds, we're going to see more inflamed tonsils and more irritated throats. And so it's not uncommon to see that irritation show up under Velscope. But again, generally it's going to show up as a bilateral presentation, which reduces any concerns that we might have. So one of the things that's, again, it really helps understand, how does cancer grow, right? How does it form? And so if I put Velscope in your hand as a clinician and I told you black is bad, right? Hey, here's your Velscope, good luck. No training. You as a clinician know how cancer presents itself. And you know it doesn't present itself in polka dots or in random shapes or in multiple locations, right? And so from that example of this tongue here is we see little black dots. And actually what we're seeing is increased blood flow to our taste buds. And this will vary from one patient to the other. But again, we have to bring in our clinical common sense as we make assessments to understand what is it that I'm looking at. Now here in the bottom left, we see a dark mass, the back of the throat. And I would say that says concern. This should be green in general. Mrs. Smith, I noticed something in the back of your throat. Do you have any allergies, a cold or something, postnasal drip that might cause some, irritation? And the patient's like, no. From that, the doc's like, why don't we have you come back in a couple of weeks just to check it out? Now, I will say this doctor's having the patient come back with limited concern. And the reason being is if we look at this picture, you can start seeing a lot of little black dots all throughout the back of the throat, right? So if this was just a mass by itself, one side, we should be concerned. But the fact that we see multiple areas reduces our concern, but not sure what it is. Patient comes back, it's still there, it's not resolving. Doctor recommends going to an ENT to get it checked out. Patient goes to an ENT and says, hey, there's something going on here. I don't know what it is. Patient gets biopsied and it comes back as inflamed lymph node tissue, which is awesome. And it's awesome because it's not cancer, but it's not normal. And so I guess through, a variety of assessments, the patient was tested for severe acid reflux and wasn't even aware of it. And this is how I want you to start thinking about Velscope. Velscope is an oral assessment tool. And this is a great example of how identifying this issue in this patient, we've actually reduced her likelihood of potentially getting the fastest growing cancer of all cancers, which is esophageal cancer. So this is something that you should be seeing pretty regularly in your practice. And it seems more common, like you'll see 4 or 5 polyps right in the back or dark sort of areas on the Velscope right in the back of the throat. And that should be your first question. Mr. Smith, do you have, postnasal drip possibly that could cause it, or acid reflux? And, maybe you should follow up with your doctor because there's something obviously causing some inflammation. But again, it's a great opportunity to have dialogue with your patient about something that's causing some type of inflammatory response. So something that's real common that you should see is porphyrin, orange or red, specific on the dorsal surface of the tongue. Great opportunity for hygiene, to have a conversation about, brushing and scraping your tongue more effectively, but generally has nothing to do with anything associated with oral cancer. What I would say though is if you see it in other areas of the mouth and it doesn't seem to be resolving, you may want to investigate further because it could be indicative of some type of infection. So white or light green in color is indicating probably some type of irritation, generally hyperkeratosis, which is positive. It means it's benign. But we always want to figure out what's going on here. What is the cause? Is there some rough edges, if you will, maybe, or in this case, in the bottom, the patient tongue was getting caught between their teeth, which obviously provides an opportunity for the doctor to remove it. As I mentioned, pigmentation is something that will be absorbed by this wavelength. So generally you will see this under white light and it should pretty much correspond to what we see under Velscope. Amalgam tattoos are something we're not seeing as much anymore, but again, that's going to be something that shows up under Velscope as well. So it's really important to understand. So melanin is one thing that we see, obviously, that absorbs. The other thing that we reference is hemoglobin. When we have hemoglobin, that absorbs the wavelength, and so it's going to appear dark or gray. And when you see hemoglobin, obviously related lesions, inflammation, trauma, once you see them a few times, you'll get a sense if something's inflammatory or trauma, or if something that could be worse, if you will. But there's a process that we always want you to go through every time you see something that shows up as dark under Velscope, assuming it's not melanin related. So when we see a lesion, one of the things we want to do first is we want to take the back of our Explorer, or skinny back of our mirror, and gently rub across it. And as you can see here, the hygienist, as she rubs across this dark area under Velscope, it's turning green. And what we're doing is we're removing the blood out of the epithelium, and we're seeing that nice, healthy collagen-based membrane. So what this says is this is a sore, this is trauma or irritation. And so obviously we can address what the cause of that is, but we can feel pretty confident that this is not a dysplastic lesion. But again, we always want to try to address it and resolve that cause. But I can tell you this should eliminate in terms of concerns in the majority of lesions you see under Velscope by just doing this normal simple process of what we call blanching or dioscopy. Does this make sense? Great, thank you. So we have to have a basement membrane, so it's really important. If we have an open wound, a fresh bite, some type of something, maybe where they jab themselves, Velscope is going to show up dark every time because there's no collagen, there's no basement membrane to sort of absorb the light. So it's going to be more stroma. So always follow your normal clinical protocols with these types of lesions. So not uncommon to have, obviously, again, irritation. But again, if this was a red area, let's say along the lateral border, how we address it? We know cancer is not going to grow linearly. This actually will blanch under Velscope. These tend to be bilateral. But again, this is how I want you to utilize Velscope as a tool for you to treatment plan, to use this as your overall approach to managing your patients. So we see this dark area, take a picture, show the patient. Mrs. Smith, you see this dark area here, this is inflammation. And inflammation can lead to changes that we actually want to avoid. We've been talking about getting this tooth fixed now for the last couple of years. Let's schedule to get this crown on here finally so we can, again, remove that irritation and remove any likelihood of that irritation causing any problems down the road. So again, I want you to start thinking of how you can use this to overall assist in communicating to your patients. Most common thing you're going to see with Velscope is irritation associated with trauma, cheek biting. And so from that, the majority of these will blanch. If you have a patient who's a chronic cheek biter and they're just biting on the cheeks all day, it may not blanch. And therefore, we have to try to remove that irritation, right, in order to confirm that it's benign. What I would tell you is if we're screening patients regularly, and this is my challenge to you, you should be treatment planning night guards for your patients, without a doubt, because you're going to be seeing this more frequently, and therefore this should be a conversation you should be having. And again, take the picture, show them this is inflammation. Inflammation is not good. Trauma leads to changes. Let's try to avoid this trauma by getting you into a night guard and hopefully reduce that. So, doctor, we have to have a diagnosis, at least a fairly confident diagnosis. And the reason being is here's an example of a lesion under white light that doesn't look normal, but under Velscope it blanches. So if you're thinking, oh, it's blanching, it's no big deal, just some trauma, great. But because this doesn't look normal, we always recommend, even if something blanches, if it doesn't resolve or if it doesn't appear like it's associated with some type of trauma or appliance, get a second opinion, get it taken care of. And then this is lichen planus, obviously, which actually has a higher probability of progressing to dysplasia. So just because something blanches doesn't mean we ignore it. So this is the example of a lesion that didn't blanch. Now, initially, you might be concerned, but to give you a little background, this actually, this is the lateral border of the tongue here. And upon doing the white light exam, the patient, the hygienist noticed that I see some dark areas on the side of your tongue, or red, specifically under white light under your tongue. Do you know how long they've been there? The patient's like, oh yeah, I bit my tongue last night, really bad. And so obviously it makes sense in terms of where those 4 dots are, which would not be associated with cancer, right? Because cancer's not going to grow that way. But they're actually blanching that other one because that is more analogous with an abnormality associated with dysplasia. And the patient wasn't sure if it was there before, so just to make sure, they had the patient come back in 2 weeks and this resolved. So what we're actually seeing is a hematoma or ecchymosis that resolved after 2 weeks. And so again, that's why it's so important to have that dialogue with the patient, understand potentially what the causes are. And again, better safe than sorry, always have the patient come back if you're just not sure what it could be. So again, that blanching technique, we have to know what we're blanching. So here we have a pigmented lesion. It's not going to blanch, but we know an amalgam tattoo what an amalgam tattoo is, so therefore assume. When we do that blanching technique, make sure you blanch the entire lesion. Just don't go down the middle, because you could have inflammation associated with dysplasia, as is the case with this lesion here. So again, make sure we're doing up and down, left or right, and we're seeing that entire lesion blanch. So we always bring this up because of concerns. Are we going to be referring 1,000 patients to the oral surgeon? And I can tell you that if we're following your protocols of assessment, unilateral, regular shape, persists for 2 weeks, blanches or doesn't blanches, you should have a pretty good sense if it's something that requires a referral. And at the end of the day, if we don't know, we don't know. And I think it's important to understand that, Mrs. Smith, we're referring to a specialist. I see something of concern, and we're going to allow them to assess, what it could be and next steps. And that's all we're doing. I always use an analogy that we would never stop our significant other, our mothers, our daughters from having a mammogram. The true false positive of a mammogram is 50%, but we wouldn't hesitate to have one or to recommend having one. I can tell you Velscope isn't even close to that, and depending on the study, it's anywhere from 2 to 12%. But at the end of the day, a lot of it is objective, right? It's or subjective. What you may think is of concern, someone else may not. So go through the protocols, and if we're not sure, then that's our step where we determine we should get a second opinion. So the process of assessment under white light is the same under Velscope. Unilateral regular shape persists for 2 weeks, and obviously that blanching technique. So here we see something abnormal. Doesn't really stand out though, right? Under white light, but under the Velscope, it definitely does. So this is unilateral, regular shape, persists for 2 weeks. And now what we're going to do is we're going to, upon blanching, refer out. Obviously, it doesn't blanch in the first visit or the second, and this comes back as biopsied as severe dysplasia, which is awesome. Or excuse me, it's carcinoma in situ, but depending on your school, it's either early stage cancer or late stage precancer in that transition zone. But the reality is no chemotherapy, no radiation, no significant surgery. Same thing with this lesion. This patient was referred for the polyp, and thank God that the polyp, because it wasn't for the polyp, we may not have found those precancerous lesions adjacent to it. If you notice, the polyp is actually green. So, example of why we have to get these denture patients in every year. If you notice here, irritation with the red, but actually under Velscope, it was dark. But this doctor wanted the patient to come back in again after 2 weeks because it actually wasn't the red in the vestibule. And we know because the doctor made adjustment, because you can see how it transitioned a little bit. So you see the dark here, and that's actually irritation from the ridge denture. When we rub across it, it blanches, it turns green. But it was actually here that the doctor was concerned about that didn't blanch, and that ends up being diagnosed as severe dysplasia, which is awesome. And it's awesome because this patient isn't going to lose their jaw. Again, avoids all the issues associated with treatment. So these leukoplakias we tend to observe, with the assumption the majority of the time, because they're benign, we don't want to observe. We want to confirm, and that's critical. We want to confirm it's benign, or confirm, or at least increase our confirmation that it's benign. So this one is not benign. This is unilateral or regular shape, does not blanch, persists for 2 weeks, and this is severe dysplasia. And I can tell you, having seen scenarios where we have cancer, lateral border cancers, and how horrific surgery is associated with it, this is something that we're ecstatic to find at this stage, because the treatment is so less significant than obviously if this was cancer. But the reality is most of the lesions we see are actually going to be benign. Hyperkeratosis, lineable lichen planus. But again, I would stress it doesn't mean we ignore it just because it shows up as green under Velscope. Is it caused by maybe a sharp edge? Is this patient healthy? Sometimes we find that these lesions become more prominent with patients with autoimmune diseases. So we always want to investigate and figure out. And I will stress, If it doesn't resolve within a certain period of time, 12 months, 9 months, whatever your criteria is, doctor, it's okay to refer, but you're referring with a strong sense that the lesion is benign. So this patient was referred to NYU for the hemangioma in the lip. And when they pulled out the Velscope, you could see the dark area on the floor of the mouth. And the oral medicine practitioner was like, probably the doctor was so focused on the lip, didn't notice that slightly raised area on the floor of the mouth. But this is why, specifically this picture, I think is so powerful, because what it says is it's hard to find things that are abnormal, especially if the tissue is identical in color, right? So if you miss this, you're not missing it under the Velscope. Velscope increases your sensitivity by over 60%. So what does that mean? That means when you do your exam and you're shining that blue light into the mouth and there's something abnormal, you have a high probability of capturing it or identifying it. But let's just say that you charge your patient and the patient says no, and you see this under white light. My suggestion is, Mr. Smith, I care about you so much, I want to do an exam on this anyway because I see something, just to confirm. And obviously we see this dark area, it doesn't blanch. We're going to palpate right below and through the floor of the mouth, and it was firm, and this ended up being a stage 1 squamous cell, but it's better than stage 4. Lateral border of the tongue, dysplasia, this is our goal. We want to find precancerous lesions. Again, a lot of things we see will be benign. Again, doesn't mean we ignore, but feel comfortable knowing that things that we see are not cancerous, which means we can manage our patients so much differently than obviously if it was something of greater concern. So last picture, again, sort of where's Waldo, but I think this says it all in regards to our ability to identify lesions that just are not readily apparent under a normal white light examination. Unilateral, irregular shape persists for 2 weeks, and this is already a carcinoma. So at the end of the day, if we see this sort of slight area under white light, great, but we ain't missing under the Velscope. And the reality is that we're less likely to miss it if we're screening, which is why, folks, we have to screen every patient possible with this technology. So one of the biggest challenges you used to have is you would see this under Velscope, you refer to the oral surgeon who didn't have a Velscope, and he's like, I don't see anything, I don't feel comfortable taking a biopsy. That's why we came out with a variety of camera options. So if you have the old camera, Canon, you can go online and sort of YouTube and see how to adjust that. I know it is somewhat cumbersome. We have the iPod adapter if you have that with the Velscope app. Take that picture, download it, store it on the iPod or download on the patient's chart, and it really gives you the ability to obviously capture the abnormality, compare from one visit to the next, and then obviously email it either directly from the iPod or through your system to a specialist for review. So, I want you to start thinking about how do we use this in your overall assessment. And this is an example of a practice that does a lot of dentures. Not sure what your denture percentage is, but the reality is you generally are making multiple adjustments for those denture patients, which takes time out of your schedule, time out of the chair at no cost. And what this particular practice started using Velscope to assist in the adjustment because they were capturing sore spots that weren't readily apparent under white light. And by using Velscope in the adjustment process, they were able to reduce their adjustments from an average of 3 down to 2, which ended up saving them not only a lot of time, but actually provide an opportunity to generate more revenue because they had more open chair time to place new patients into. The other thing to consider, I'm not sure if you offer Sonicare or Oral-B, but if you are selling those to your patients or offering those to your patients, it can be somewhat challenging because obviously they can get them at the Walmarts. But when you see that porphyrin, take a picture. Mrs. Smith, you see this red, this is called porphyrin, or in layman's terms, bacteria poop. And the reality is it's just hard to get that off with your manual toothbrush, but with our mechanical toothbrushes, with the Sonicare and the Oral-B, is so much more effective in terms of getting that excrement off out of the crevices, if you will, the tongue, which is another reason why you should really consider this besides obviously general oral care. So a great way to help educate and reinforce that value. So just for your, to reiterate, there's tons of clinical data on the Velscope. Go to the website, you can find more, but I just want to reiterate that there's more study on Velscope than probably some of the things that you use every day, like some of your composites actually that you may use, just to reinforce sort of how effective this is. So one of the things we want to talk about is implementation. We know that we think it's actually easier to screen, and the harder part is getting your patients to accept. There is a code for reimbursement, D0431. It's limited. I'd say probably about 20% in this area, or on average nationally, accept the code. So we recommend submitting it. There's a medical code, so if you ever considered billing under medical, that's one thing you might want to consider as well. But at the end of the day, what we do find is you want to have a reasonable fee. And on average, doing surveys, the average fee is around $22. But we have some practices that charge $65 and get 90% acceptance. We have some practices that charge $15 and get 30% acceptance. So what we've come to find out, it isn't just the fee, but it's also how you present it so the patients understand the value. If you just have the patient sit in the chair, Ms. Smith, we have this test, it's not going to get covered by insurance. It's going to be $20. Shall we move forward? You're going to have a lot of patients to really think about it. Our recommendation is let's educate the patient, let's help them understand the value, and then from that, let's make it easier for everyone when it comes to relaying that. So, one of the things that you want to do is make sure we understand what Velscope is, right? I can tell you, normal, if you're sort of stuttering, it's a blue light, it helps us find cancer. It's sometimes for some patients that's not going to be enough. So I use a simple description that you're going to feel comfortable with, that you can relay in a very quick, Ms. Smith, this is a safe blue light. It doesn't cause any pain. There's no radiation, but what it allows us to do is to see below the surface where potential harmful changes can begin and capture them early to avoid something becoming more serious. Or it's just something that allows us to see things we just can't see with the naked eye, but it's something that we really believe in, really sort of feel strongly that you should have at least once a year. So just something to get comfortable in terms of the dialogue. One of the things we also felt, and as you know, we provided you some different verbiage that you can use as templates for you to get comfortable with. But I would tell you I'll share with you an example of a practice that was getting 90+% acceptance in a very rural community. I would definitely say below middle class. And in their dialogue to understand what is it that they were doing, they were really methodical. And basically, they were providing information to the patient up front when that patient checked in. So whether it's a brochure, whether it's a lamination of the brochure, whether it's your own piece from the materials that we provided. But, Ms. Smith, as they're checking in, signing in, Ms. Smith, this is, thank you for coming in. This is some information about a service that we now provide that the doctor wants every patient to have. Please take a second to read. If you have any questions, you can ask the hygienist or doctor when you go back. So now instead of looking at their phone or reading People magazine, they're reading about why this examination is important. They're reading about what it is. They're reading about HPV for the first time. For some patients that it's, it provides credibility that this was on Dr. Oz and the doctors. But again, something that provides upfront information. And why this is so beneficial, not only does it provide value, but they also found that it saved time for the hygienist to have to explain sort of in detail. And for some patients, the 20 questions were going to be reduced. So now they come back. Mrs. Smith, did you have a chance to read the brochure? Shall we move forward? Well, how much does it cost? Does insurance cover it? Those are generally going to be the common questions you're going to get. And so as opposed to saying, well, insurance isn't going to cover it, which again is, and we in all sincerity, you don't know. this is what they were using. You know, Mrs. Smith, the normal cost of the procedure, and most Delta Dentals, their schedule for this code is $65, which they rarely reimburse. But the normal cost of the procedure is $65. But you know what? The great thing, and it's really important to use that word great with your insurance, the most you're going to pay out of pocket is $25 that you're charging. You know, shall we move forward? If it's covered, it's great. If it isn't, then the patient knows that's going to be their out-of-pocket cost. It just makes it simple and easy, but it reinforces that, you know, one, they're getting a discount, and you can add to it. You know, Mrs. Smith, the normal cost is $65. We're reducing that price because this is how important we think this is. That's why we're only charging, you know, $25. So it's just really important to get comfortable with that verbiage. If we're going to use a waiver form, you can use that at that point. But that's something that I would, again, add to the back. So if we find something suspicious, you know, doctor, obviously in consultation with your hygienist, you're going to refer out appropriately. But again, we want to stress we haven't diagnosed cancer, so we don't know what the surgeon's going to do. We would just say, again, refer for consultation as opposed to biopsy. And the patient, what if I have cancer? Ms. Smith, we don't know. We're just referring, you know, just like if you have something on your skin, doesn't mean you have skin cancer. It just means we just want to get it checked out. So great service that we have now available for you. If there is something of concern, let's just say you're just not really sure what to do, you can take a picture, provide all the history of the patient, color, you know, age, history, no names of patients. Again, HIPAA compliance, you refer it to LED, and then they will actually refer to literally world-renowned oral pathologists that will provide an assessment as to what it could be, and actually direction as to what your next steps should be as well in terms of management. All right, so with that, we're gonna have a few minutes to play around so we can look in each other's mouths. Everyone's different, but goggles are for the patient. Up and down, left and right for the mouth, back of the throat. It shouldn't take more than a minute and a half to do a thorough exam. You want to be about 2 to 3 inches, but no further from the oral cavity, or 2 to 4 inches, but no further than 4 inches. If you want to hold it up to your eye, you can, but you know, anywhere from 2 to 4 inches from the back of the handpiece as well. You know, our suggestion is, though, if you wear loops, establish your normal distance first. In terms of your focal point in the mouth, and then bring the Velscope in, because there's no magnification in the Velscope. And from that, it really is like a 5 to 10 sort of patient learning curve. It's just getting comfortable with your distance and your angles. Obviously, if you can turn off the lights, great. It's meant to be used in a fairly lit operatory, but I will tell you, you know, if it's bright sun coming in the afternoon, you definitely want to block that light some way, because that will obviously reduce that contrast. Want to stress, it is critical that you use the Vel cap and the Vel sheath. They are meant to be disposable. Number one, most common thing that we find in terms of Velscope is damage to the Velscope because of cleaning agents that seep in, specifically around the lens. So use that Vel cap, and it's meant to be disposed of. It is, you cannot sterilize it by wiping it down per CDC guidelines. So please do not. There's been some issues that we've had where there's some concerns of transmission of issue, you know, that we want to avoid. So with that, I thank you very much. Let's go in the operatory and play around with it a little bit. Who's our guinea pig? And we'll enjoy getting you guys up and running. Take care.